Good afternoon, everybody. My name is Dr. Zeev Kain. I'm the president of the American College of Perioperative Medicine. This afternoon, we have a very special webinar that is supported by Medacta USA. And the topic of the webinar is a shift in outpatient in total hip procedures to the ASC. It's a topic that has been in the news for a couple of years now, but certainly now with COVID and with the move to more patient-centered care and more value-based care, it got accelerated even more. When I first spoke with the president of Medacta, Eric Dremel, and with Sean Fitzsimmons, who works with him, we kind of discussed how to organize the webinar. And the general consensus was that we should start with a strategic point of view, move from there to operations, and of course, then close it up with clinical. So that's how the webinar will just generally work out. Now, we're going to start with a number of housekeeping items. So if I can have the next slide, that would be great. Here are, you can see the description of the GoToWebinar. You can see the platform right in front of you. So here's the computer audio, the phone audio. You can orange open and close on control panels. And any questions, just type them in. As a reminder, we'll have 3 speakers, each one 15 minutes, and then at the end, 15 minutes for questions. So please feel free to be engaged. We'll love that. Next slide, please. And then it's just a reminder, Q&A at the end. Technical issues, please let us know through the chat box, so we'll help you as soon as possible. And then we will send it out. The handout will be sent out, and later on, instructions on how to access the recording for those of you who want to hear it again, because it's going to be so good, or just in case some people who could not have joined us. With that in mind, we're going to move right ahead to our next speaker. And it's a great pleasure for me to present to you Dr. Randy Fagin. Dr. Fagin is the corporate vice president with responsibilities over the surgical service lines at HCA Healthcare. Now, I know everybody knows HCA is gigantic. What I didn't know is that they have over 300 hospitals by now, and ASCs, both in the United States and the United Kingdom. And Dr. Fagin has a very special perspective because he's a surgeon by training. And now he's doing his corporate job at HCA, and he's going to talk to us about the shift from total hips to ASC, the strategic overview. Dr. Fagin?
Zeev, thank you. I appreciate the opportunity to be with you all today. I'm going to talk from the hospital perspective and how we're looking at the outpatient shift. And I'm dividing into 2 sections. The first, we'll talk about kind of future projections, quantifying the impact to our hospitals, and strategically as a hospital system, how do we think about this shift? The second piece, I'll go into consumer confidence and how does this shift, how is COVID impacting the shift in terms of perceptions of safety? What do we think is going to happen in terms of impact on volume? And what are the challenges and strategies for hospitals around the consumer confidence side? So let's start with the outpatient shift. Outpatient shift, as Zeev mentioned, it started a number of years ago and it's continued to accelerate. You know, when we saw COVID hit, we saw a massive, obviously, dip in our procedures that everybody shut down electives. When it ramped back up, it was almost as if there was an accelerant placed on the outpatient shift. If we track that out, it looks like the loss of inpatient, which is around 32, 38% down across the nation, is going to be stable. We don't see that coming back, to be candid. What we see is 100% of growth on the outpatient side, split obviously between the hospitals and the ASCs. So let's talk about what this actually means at the hospitals. Let's do some math here. So use Medicare reimbursement, which obviously is the lower of the reimbursements that are available to our facilities and our physicians. If we look at, there's a general, and there's factors for elevation based on markets. So I took a general a nationwide average here. Hospital inpatient, just over $14,000 or just under $15,000. Hospital outpatient, about 20% less than inpatient at about $12,000. And ASC is about $8,600, about 40% less than inpatient. So if we look at a hospital, like St. Elsewhere Hospital, that did 1,000 joint replacements a year, back in 2018, when all this was just starting, we were sitting at about 70% inpatient and 30% outpatient. If you run the math on that, you end up with 700 cases inpatient, 300 cases outpatient, and at those reimbursement levels, you end up with a net revenue of about $14 million. If we fast forward then to 2021, we're on a runway to actually flip that and to end up at about 30% inpatient and 70% outpatient, with about a fifth of the outpatient, about 20% of the outpatient being in the ASC. If we run the numbers on that, we end up with 300 cases at the inpatient rate. Outpatient is split between the hospital at 11,900 and the ASC. And with that delta in dollars, you end up with a total net revenue about $11.8 million, or essentially a 16% loss in net revenue. To make up for that 16% loss, the hospital needs 20% higher volume. So in order for me to get from the 11.8 up to 14, I actually need 20% higher volume at the new mix of 30/70. What does that mean to us as a hospital system? Well, that means as we think about gaining 20% volume, I can't do that one surgeon at a time. I believe you're going to see hospitals moving from surgeon alignment to group alignment. And as we think about group alignment, there's going to be three big buckets we're going to see it. One, you're going to see hospitals becoming a lot less inpatient-centric. We recognize the outpatient shift is happening. We recognize that it is negatively impacting our bottom line, which means we're going to have to find a way to make up for that in volume. So I think you're going to see hospitals embracing across sites of care hip and knee replacement more than they have in the past. Second, I think you're going to see hospitals finding ways to be more focused on shared value-based goals, trying to hit the trifecta of cost, quality, and experience, and finding ways to actually partner with physicians, not just have them as providers of care in their facilities, but actually partners in that process to be focused on that value-based goal. Last, I think, and especially with the new CMS guidance that's come out around the anti-kickback statute, I think you're going to see new financial alignment vehicles that are becoming a lot more popular. Things that before were either risky or in a gray zone that made hospitals uncomfortable, now actually being allowed. I think it's going to open up the opportunity for financial alignment vehicles that we haven't seen before. So let's move over to the consumer confidence piece. Let's start with perception of safety. It's interesting, if we look at the economic outlook, less than 25% of the U.S. is optimistic about the economic recovery. If we go a step further, 94% of consumers are afraid to visit a hospital. What's interesting actually about this is consumers are not differentiating between sites of care, meaning they don't feel more safe in an ASC than a hospital. They don't feel more safe in an urgent care than an ER. They are viewing all of these areas with equal amounts of risk. It's a huge number of patients that are afraid to go into a hospital. If we drill down one layer further, 86% of consumers say they will delay an elective procedure right now. Now, we know that COVID is not curing our osteoarthritis. We know that patients who are in pain and are having mobility issues are going to need to have these surgeries eventually. But in the near term, we're going to see folks pushing that off to a significant degree. If we see what is the impact of that pushing off, right now across the nation, if we look from March through July, there's been about a 35% decrease in OR volumes. Now, obviously, we've seen OR volumes continue to slowly, gradually come back up. But even with this next surge, this third surge that we're seeing, we're already seeing hospitals and counties shutting down elective procedures. So I think we're going to see this suppression of volumes in the hip and knee space continue at least to the early part of 2021. When we look at the surgeons and they look at their office volumes, over 3/4 of orthopedic surgeons expect their procedure volumes to be down versus prior year, with half of that group expecting it to be down more than 25%. These are significant volume shifts for our providers, and these volume shifts are likely to continue through the early part of 2021. So how are hospitals meeting these challenges? What are hospitals doing to try and make patients feel more comfortable, more safe? How are they partnering with physicians to create these environments? About half of hospitals are finding it difficult to even provide that care. half of hospitals are seeing workforce shortages, and inpatient bed availability is one of their top 3 challenges. And it's interesting, you say, well, if all these patients are removing themselves from elective surgeries, why are hospitals finding it so hard to meet inpatient bed availability in workforces? Well, we've seen a large number of our nurses actually exit the workforce. We've seen folks actually move from full-time to PRN. We've seen travelers actually increase because of some astronomical salaries for nurses in a number of our markets. And it's putting some significant challenges in our hospitals. This latest surge of COVID has actually impacted our med-surg availability more than our ICU availability, candidly, which means that our med-surg floors are getting compressed. And if you pair up a med-surg floor compression in terms of availability of beds with a nursing workforce shortage that is national, not just local, it's a significant issue in terms of hospitals' ability just to meet the elective demand because of the demand that COVID is placing on them in addition to that. So how are hospitals working to try and combat this? It really is about optimizing throughput. The one thing that hospitals are spending the most time on is how do we optimize throughput? How do we create a more efficient, safe environment for our patients that improves our ability to safely and effectively not waste time, not waste resources, not waste care, and provide the most efficient, effective, safe care we possibly can. How are we doing that? There's really 3 ways that you're going to see hospitals focusing. And it really all comes down to technology. One is automation. You're going to see hospitals investing in automation as a means of removing the work effort involved in providing some of these care. I mean, listen, if you fly on an airplane, just about everybody pulls up their boarding pass on their phone now. You don't log on your computer and print it out on a printer and then bring that piece of paper in with you. You go on your computer, you hit, you're gonna sign in for your flight. If it's less than 24 hours, you touch the button, you hit to stick it in your wallet, it goes in the wallet of your phone, and off you go. That automation has reduced our need to call people up for people to print things out. We don't even go to the checkout counter and have them print things out anymore. Automation has removed a level of burden from our travel. In the same way, hospitals are looking to use automation to remove a level of burden for patients and their families, and in doing so, improve efficiency and throughput. Real-time information is becoming critically important. The idea that we look in the rearview mirror and look at statistics from a week ago, a month ago, a quarter ago, 4 quarters ago, if you're looking at market share data, is becoming increasingly archaic. Hospitals are actively investing in real-time information. When you can provide patients and families and nurses and care providers with real-time information, you can actually improve satisfaction and improve efficiency simultaneously. And lastly, you're going to see customizable workflows. You know, the idea that one workflow fits all models is just not the case. You're going to see hospitals investing in systems that create customizable workflows for specific parts of the hospitals to meet the near-term needs of that environment at that moment, at that time, in that day. Thank you.
Thank you, Randy. I have about 5 questions for you immediately, but we'll have to get to the end of this. So we are now going to move on from the strategic level to more of the facility level. And we are lucky to have with us Brandon O'Dell, Mr. Brandon O'Dell, who is the Director of Clinical Diligence and Integration at SCA. And for those of you who don't know, SCA is an organization that either owns or manages over 220 ambulatory care facilities, surgical care facilities in the United States. It's interesting to see how Brandon is going to take what Dr. Fagin just said, and let's see how much of that he actually implements when he integrates these facilities. With that, go ahead.
Dr. Kain, thank you for that introduction. I've had the privilege of serving as a registered nurse the last 26 years, and I started in the hospital working in total joints, and have actually chaired a total joint committee in the hospital. My background is in critical care. I took care of these patients back in the late 90s when these cases went very wrong. And so I entered the ASC setting in 2011 and have started to see this shift come over. And so with a background of knowing how these cases can go wrong and how much work it takes to actually get a program going, it's a pleasure that I get to share some of this data with you. So the learning objectives, there's 3 stages of planning. There's physician readiness, facility readiness, staff training, and then there's pro forma to understand the costs and the opportunity, and then there are facility contracts and costs. I'm going to skip this slide because Dr. Fagin did a great job of showing the shift in volume from the inpatient to the outpatient setting. I just shared this slide from SG2 showing the latest data to confirm that we are in a flip from 70-30 to 30-70. So the 3 stages of planning. The first thing, physician readiness. Physician readiness is a key component. The physicians are excited to pull their patients out of the hospital setting and do their procedures in the ASC setting. There's some checklists and some checkdowns, though, to make sure that the physician actually has a good idea of what it takes to pull a patient out from an inpatient setting to an outpatient setting. The first one is the physician performing same-day discharge in the hospital or hospital outpatient department? In other words, if your surgeon is not discharging that patient on the same day in an inpatient setting, how are we going to discharge this patient in an outpatient setting? So a key component is making sure that that physician has had some numbers under his belt. How long has he or she been discharging from an inpatient setting within 24 hours? The other thing, and another critical, is outpatient patient selection criteria, especially if you're launching a program. It's better to go slow, have an excellent patient selection, little to no comorbidities, engaged patients that are, that are going to be your first ones through the process. Outpatient anesthesia and pain management protocols. How good is the relationship between the total joint surgeon and anesthesia in the hospital? Is that anesthesia provider in your outpatient setting? How comfortable is your anesthesia provider in your ASC at providing pain management in the total joint realm? And have they had success in pain control for the patient undergoing an outpatient total joint and getting discharged within 24 hours? So the other component is really managing expectations and timelines and equipment. I see a lot of physicians just eager to do a case and then build a program around the case that you've done. And I really think that's putting the cart before the horse. I think the expectation should be to establish and set a program that provides the safest possible situation for a patient to have one of these procedures. This would include setting up programs, processes, policies and procedures, mock cases. In other words, try everything that could possibly go wrong and make sure that you solve for it before your first patient gets on that table in the outpatient setting. Encourage your physicians to slow down and make sure that all of the boxes are checked before first patient. Now let's look at the facility. Facility readiness. It's important to do pro formas and look at the volume and the financial feasibility of starting a total joint program. Do you have one surgeon interested? Do you have a group of surgeons interested? If you have one surgeon, is that the right surgeon? Because there's a title that's important in an outpatient total joint setting, and that is physician champion. And the physician champion is someone that's going to help own and oversee this program and help the clinical staff and anesthesia check this down from start to finish. The pro forma will let you know, hey, is this going to be financially feasible? Is my capital outlay going to be so significant and my surgeon's volume so low that it doesn't make sense? Look at your sterile processing department. I've seen total joint and spine centers with no washer. I see SPD techs in there scrubbing these instruments by hand. What's the capability or the capacity of your sterilizers? Are you going to have to gut your SPD, throw in a washer, a triple bay sink, and a sterilizer that can hold all of these trays? Do you have room in your SPD department to do that? What about the other storage availability in your ASC? Where are you going to store these trays? What about the HANA table if you're doing an anterior approach? These items take up a lot of square footage. It's square footage that ASCs simply don't have. A lot of them are busting at the seams. A lot of them, especially during a pandemic, have tried to stock up on PPE and the like. Where is all of this gear going to go? Managed care contracts and added cost preparation. You've got to work with managed care. You've got to see. You've got to see how long is it going to take to add these CPT joints to your contracts. In some cases, it's 6 to 9 months to even be able to do a total joint. So if you come out of the gate with a surgeon that wants to get away with doing a case and building a program around the case that they've done, you might not even be able to get reimbursed for it for 6 to 9 months. So working closely with your managed care companies or your managed care contract or the payers directly is really important to get a feasible timeline of when you can start a program. Facility staff trained and successful mock cases performed. I mentioned this early. You can't do enough mock cases. You can't provide enough education and competencies, not just to your OR staff, to your pre and post-op staff. Staff training, everything from identifying clinician to manage the program. Is this a director of nursing? Is it a CEO? Is it combined? Is it an OR charge nurse that knows this? Is it a CST that scrubbed these cases for years? Identify your in-house clinician champion that's going to work with the physician champion. Create complete patient care pathways, which includes, creating the patient education class. Some of this stuff, like Dr. Fagin was referring to, can be done online with accountability, with tests after these people watch online education classes. Education for all staff, including annual competencies, is a must. So planning, financial and clinical considerations. Identify the opportunity from current partners. How much volume is going to come in? Confirm that SCD can handle anticipated volume. Review surgeons' preference cards. This is key. If they're wanting specific positioning devices, if they're wanting certain instrumentations or implants, make sure you do your diligence to go through that preference card thoroughly and ensure, by all means, through your mock cases, that you have everything on that surgeon's preference cards and that the surgeon is involved in the mock case. Complete pro forma and share with the partnership. So after you've done your diligence, your pro formas, and after you've done your capital outlay requirements, after you've done your diligence in SPD and your storage, you bring that stuff, you bring all that data to the board meeting and present it in front of the physician champions, and the partners to make sure that this is the right move for the ASC. Facility contracts and costs. You have to select the proper CPT codes. You have to set the correct charge master. Identify the payer mix of the surgeons planning to perform the total joints or total hips in this case. Work with the managed care team. Identify reimbursement per surgeon, per payer. Review those preference cards. Work with the supply chain to secure competitive pricing. Presenting that volume shift from the hospital to the ASC and having actual pro forma data to present to your supply through the supply chain to your vendors is a great way to work on reducing the cost. Understand implant coding and billing methodology per payer. So you're working with your front office and your business office manager and you're coding to make sure that everything is getting reported appropriately. You've got to develop your policies and your procedures. You have to train your overnight staff, extended stay physician orders and protocols. You have to develop 23-hour order sets. You have to determine, is the surgeon taking call for this 23-hour patient in the ASC, or is the anesthesiologist doing that? How are you going to reimburse them? You've got to develop 23-hour physician orders. That way you're really contacting these guys or girls with something that falls outside of the box. You know, make it 95% complete on these orders so that the physicians can call you for updates instead of you calling them. Overnight policies have to be written. Make sure you've got a comfortable mattress for your patient to sleep on. I see patients staying over in ASCs on a 1 or 2 inch mattress. Can we get 3-inch mattresses under them? Meal planning. Does your state require you to have meal planning preparation and checkoffs? So know your state requirements as well. Everything must go and be approved through your medical executive committee and your governing body. Secure physical therapy for the patient. We're seeing a big shift in the outpatient setting right now with instead of patients coming in for a boot camp, if you will, and being taught physical therapy and being taught the pre-op, clean your house of rugs and put your find someone to care for your pet for 3 days and all of these kind of things that are reviewed and incision care and gait training and all of this stuff is now being done via software with tests being taken. But you know, PT is still important. Are they going to PT at the orthopedist office? Are you having a physical therapist come out and check them off? Are you doing it online? Planning, surgeon credentialing. So define the complete surgeon credentialing and privileging. Define the criteria for the total joint privileging. The Med Executive Committee has to formally approve the procedures with documentation and approval in the meeting minutes and add procedures to the facility's list of approved procedures, as well as confirm the surgeon has delineation of privileges, ask surgeon about all potential outpatient procedures. Potential complications. So you got to establish a plan for complications requiring higher level of care. You have to manage the hospital relationship regarding the launch of your total joint program. Even though, as Dr. Fagin referred, that this big shift is coming, we still need our hospitals. We can't serve the total hip community completely in an outpatient setting. It's not safe to perform these procedures in the outpatient setting for everyone. There are folks with comorbidities that require them to be done at the hospital. Not only that, there are instances that things don't go well in the ASC setting, and you have to have your transfer agreements, and you have to have your transport agreements and be able to lean on these hospitals in cases where things have not gone as planned, if you will. Ensure you and the surgeon have updated your transfer agreement. Do you have admitting privileges to the local hospital? Equipment protocol plans for fractures and intraoperative complications. Are you going to house Balmile cables in your ASC? Are you going to have them on backup? Measuring outcomes to continue enhancing the clinical excellence. Having a solid quality program where you're reviewing data very frequently with your medical director, with your physician champion to find ways to continuously improve these procedures being performed in the outpatient setting. align on patient selection criteria, anesthesia, pain management protocols. From a total joint committee with clinical and operational leadership teams, SPD, material manager, surgeon, and anesthesia. Select a strong anesthesia provider to partner with for perioperative protocols. Surgeons, anesthesia, and MEC to define the patient selection criteria. Develop preoperative patient education or boot camp. Like I was saying, this can be done online or it can be done at the facilities. As Dr. Fagin was saying, a lot of folks, they're not only afraid of the hospital, they don't want to come to the ASC to have a boot camp like we used to in the past. So you have to be adaptable. You have to be nimble. You have to be able to change your process. Develop an online boot camp. Film your ASC. Film it from the outside. Show them what they're going to see. Show them the pre-op nurse and the registration, and show them the OR circulator, so it's not scary for that patient going in the first time. Be adaptable. Be nimble. Both the patient and their post-operative caregiver should be educated. Who's going to take care of this patient? How well have they been trained? Have you prepared them for helping with transfers to bedside commodes and the like? Is this person able to help, get food and drinks and pain medicines to the patient in case they're having difficulty getting up or transferring? And then also come up with a total joint replacement handbook so that they have something to lean on in their recovery period. This education includes review the procedure medications, discuss infection control, discuss post-operative PT requirements for discharge, what to do before surgery, what to do and not to do on the day of surgery, what to bring with them, home health needs, and any required durable medical equipment. If you guys have any other questions or concerns, anything I brought up, feel free to email me. I'm happy to answer questions, and I'll, of course, stick around for the end of this presentation. Thank you for your time.
Wonderful, Brendan. Thanks so much. And I think it was an excellent transition from Dr. Fagin, who talks strategy, to Brandon, who talked about, okay, how do you actually operationalize it in a single facility? And now we're going to move to, if I can say, the cherry on the cake without anyone getting upset at me. But I think at the end of the day, clinical care is very important. And so we are now going to move to an orthopedic surgeon, Dr. Andrew Wickline, who is actually going to talk about surgery performed in ASCs. Dr. Wickline is a hip and knee specialist in upstate New York. I first got to know him through the rumor mill because I've heard about a surgeon who has excellent outcomes, very low complication rate, and actually very low cost as well after discharge, with a super low opioid requirement. So I said, I want to know him. And so I was fortunate enough to be connected. And Andrew is going to talk today about his technique for outpatient surgery. Andrew?
Thank you, Zeev, and I appreciate the opportunity to speak tonight. So again, I'm going to talk a little bit about outpatient total hips in the ASC setting. We'll go back one here. My disclosures, I have consulting agreements with a number of different companies. So I'm still old school. I like an outline. This helps me organize my thoughts. So we're going to talk a little bit about my personal stats with this protocol. Going to really kind of reiterate many of the things that Brandon said about education and training the staff and the family. I'm going to talk about how we get to these ultra low opioid pill usage, and again, how to help control and manage the pain postoperatively with a home plan, daily checklists, and then a complication plan, just as Brandon mentioned. So here are my personal stats. We published this data. 97% of all comer hips in my practice use 10 opioid pills or less through 6 weeks. With at that time 70% using tramadol. We're up over 90% now. So the majority of my patients get 10 tramadol only for post-op. And if you look at the bottom, there's the reference for our published paper, where the average patient uses 3.5 pills through 6 weeks. 40% use 0 opioids after discharge. Additionally, I'm going to break a little bit with Brandon. 95% of my patients use 0 therapy through 6 weeks post-op. Again, we published that. And interestingly, looking at the numbers that Randy and Brandon both showed, at the time of this paper, I was 64% same day discharge. Now I would say I'm 90% because of COVID. So I know you're seeing 70% is the current goal, but I think it's going to be a higher number than that. I think this has radically and permanently changed the landscape for patients staying in a hospital. Our annual complication rate for all comers is 1.2% through 90 days. And in addition, as Zeev mentioned, we were able to see a very low cost through 90 days, which we'll show on the next slide. Here's a copy. I was fortunate enough to meet some people through Value Stream. They convinced me to self-convene my own bundle. You can see my target goal was quite low to start, so we were doing quite well. Unfortunately, that led to only an $1,800 profit per case. But when you look across the nation, many people weren't able to meet their bundle price. In fact, Rothman's group at AUKUS last year, in 2019, showed that they were unable to beat their target price of $19,200 or something like that. And you can see we were able to do so at $15,370. Remembering that the majority of that cost is the facility hospital fee at over $12,000. So once you add the surgeon fee, PA fee, and the anesthesia fee, and you remember that these also include hip fractures, we were able to have a remarkably low 90-day care cost for all comers. So how to become an outpatient surgeon and not to be the last one of the party. I think this is the most important slide for the surgeons who are in on this talk. You need to invest in your practice. Every quarter I fly out and operate with someone new. Anyone that I hear that's doing a better job than me, I want to know what they're doing and I want to bring it back to my patients. And I think we should all be doing that. Doug Dennis told me a number of years ago, Wickline, you need to take at least one day off a week and invest in research and invest in your practice and not be on the hamster wheel. And it was hard for me to listen, but I did it. Craig McAllister said the same thing with SwiftPath. He spends a half a day per week not doing clinical duties, but really investing in his practice. And I think this is an important step for my surgeon colleagues. So you want to review your specific processes. You want to identify where you can improve and start with the low-hanging fruit and make a timeline. I find that when I create dates, both for myself and for my colleagues, that I want to accomplish something, it gets done. But when you have a vague, geez, I'm going to get this done in 2021, that you find out that it's suddenly November of 2021 and you haven't become an outpatient surgeon yet. As Brandon mentioned, start in the hospital. That's what I did. And then transition to the ASC. Remember how Academy said to learn how to do arthroscopic shoulder surgery? You start with 45 minutes of doing it arthroscopically, and if you're not having success, you convert to open and again keep the patient safe. But again, that allows you that transition period. Patient preparation is the most crucial step in my mind. And you can see on number 3 here, I think this represents at least 1/4 of your success and maybe as much as 2/5. I agree with Brandon. You need to have a booklet or at least a digital version of your personal beliefs and convictions, not the one that the hospital makes for all of the surgeons who come to that facility, but you specifically. Your patients want to see your face on it. They want to understand why you're making these decisions. This takes time, and it took me 6 months, although there are now companies that can help you do this. I personally recommend print, just as Brandon said, because even in best case scenarios, 15% of patients have no digital access. Surgery is anxiety provoking, and you should control anxiety with education. On a personal note, my wife was treated for cancer a couple years ago. We went to a couple of different surgeons, not a single pamphlet, nothing, just 15 minutes of shell shock sitting in that room and then walking out saying, what did he say? What did she say? So, ultimately, I had a colleague down in Philadelphia that was able to point us to this American Cancer Society book. It really helped us. So I can tell you now, being on the other side, sitting in the opposite chair that I sit in every day, being the patient, that book is very, very important to your patients. As you can see, this is my 6th edition of this book. I'm currently engaging and working on my 7th edition. I try to rewrite this and review it every quarter, although admittedly it may be every half year, depending on how busy we are. But patients, if you remember back in medical school, patients retain only a fraction of what is taught and explained to them in the office. And they're afraid to ask the surgeon certain questions. Write it in your book. Having this immediately available reference with checklists makes a difference and helps on their roadmap for recovery. If you do not have patients engaged in this process from the outset, I can guarantee you that you will have patients that will fail or will barely get through the outpatient process. So you need to also encourage your team to let you know which of those patients that has not complied with the class attendance, has not seemed to read, when patients come in, they bring the book with them. My medical assistant will say, Andrew, the book, the crease, there's no creases on the binding of the book, telling me that the book has never been opened. I immediately go in and have a discussion with that patient and ask if they are really ready for surgery. Because if they haven't read the book on that visit 1 week prior to surgery, they're not going to succeed. Additionally, the book talks about getting the house ready, just like Brandon said. You need to have the grab bars. You need to have the raised toilet seat. Patient optimization. I think patients need at least 4 touch points prior to surgery. There's that initial patient decision to move forward. Typically, either my PA or myself make that determination. Then those patients have to go out and get the labs drawn immediately. As we talk about here in the next point, they are not allowed to schedule surgery until myself or my PA, my mid-level, has signed off on a normal hemoglobin, a normal or close to normal hemoglobin A1C, a normal albumin, and normal kidney function. If those things are abnormal, I want those addressed before we start booking a surgical date. Number 2, the patient does an education class online, just as Brandon talked about. I ask my patients to have 1 pre-op PT visit with a vetted therapist, a therapist who believes in my protocol, and then they finally meet with me prior to generally a week before surgery to go over any final questions and review the book. Additionally, I verify and demand smoking cessation. I use 40 as my BMI cutoff. If someone's 48, they get down to 42, they've made a really conscious effort, they're hitting a plateau, yes, I'll fix them at 42. That patient is engaged and wants to have success. I also would want you to strongly consider having those patients who are on narcotics preoperatively start cutting down on those narcotics. And then lastly, sleep apnea and urinary retention screening. You need to train your staff and your family who's going to be the coach. Every time that you go down to Florida to that famous theme park, everyone says the same thing. Hello, it's a magical day. How can I help you? Everyone on your team needs to be saying the same thing. It is reassuring to the patient that everyone is on the same page. I love it when a patient actually corrects a new team member or a new nurse and says, that's not what's in the book. Are you sure? Because that forces my team member to read the book. And at the same time, it really shows me that patient has bought in. Pain control is important, as well as complication avoidance. I think we all know about preemptive meds. I do not use any preemptive opioids. It is not necessary to give patients opioids in the pre-op holding area. We do use some steroid for those patients who are not insulin dependent. We use anti-nausea medicine, some Celebrex, some acetaminophen, and gabapentinoids. The type of anesthesia I think is important. It is my personal belief that general, and with data that we've shown in our own surgery center and hospital, that general anesthesia actually is more likely to provide consistent discharge times. We saw a minimum 2.5 extra hours of hospital or ASC stay when spinal was used. So if you're going to use a spinal, I know there's data out there talking about that spinal is safer for patients. At least have your team get away from the bupivacaine, use low dose bupivacaine, or ideally chlorprocaine, or if they're willing to review the data on lidocaine, consider that as well. From a surgical approach standpoint, I have several thousand hip replacements, both posterior as well as direct lateral. But since 2008, I'm 99% direct anterior. Personally, I'm not going back to those other approaches. There's clear improvement, at least in my patients. Lastly, the length of surgery needs to be less than 40 minutes from incision to closure. If you're not able to get into that realm, then go and find another surgeon that is, just like I've been doing over the years, because that's in the best interest of the patient. I just use a periarticular block. I currently use clonidine, Trim, Toradol, and Marcaine. I trialed liposomal bupivacaine twice. I just could not see a difference with that. We saw no difference in pain scores and no difference in opioids. So 2 separate trials, 100 patients each. I trialed the fascial iliaca blocks. Again, no significant improvement, at least for my technique. I do think aggressive fluid resuscitation is important. In the hospital or in the ASC, you want to use cryotherapy right away. IV NSAIDs such as the ketorolac, I think, is a real big help to stay away from the narcotics and then get patients up. The biggest thing I tell patients and my staff members at both facilities, you need to warn the family about that first 48 hours risk of syncope, particularly when they go to get up and immediately start walking. It's the young patients who are, I find it to be at large risk, as well as the elderly male patients after they empty the bladder. We've all heard about those patients in the bathroom. That's when the falls occur. There is clear data showing that there's a post-micturition drop in blood pressure. I'm still looking for an ideal algorithm for patients at risk for urinary retention. I need to move along here. We're running out of time. Discharge plan, I think your coach needs to come in that last 30 minutes into the facility. They need to hear the information from the discharge nurse. I think there's a lot of data that's really coming down the pike about nutrition. I have 2 products that I currently recommend, the Mend product and the Isopure product, both of which can help with supplying much needed proteins at the time of the injury. The Mend company has 7 studies out there showing significant reduction in the cytokines after surgery. I think those are the things that kind of really screw up the sleep cycle for patients. So I really have interest in this. Future areas of thought are CBD oil and extended tranexamic acid. There's a group out of China showing that 5 doses of tranexamic acid significantly reduce those cytokines further. So I think more study needs to be done in the US on this. At home, I have just a simple checklist. I have patients walk once an hour and do ankle pumps. We do not have patients who sprain their ankle or break their ankle try to walk a mile in the first week after spraining their ankle. So why are we doing that for hip replacements where I cut the bone and I shove a big piece of metal down the inside of the femur? It doesn't make any sense. And so for hips and knees, I try to do 0 therapy the first 6 weeks. And it turns out most patients are happy with this. They save money, have less pain. A clear pain management plan. Again, I think most of us know about these different multimodal medications, so I'll try to leave this and it'll be available for view later. I think Zeev's going to get it up for anyone who attended.
Okay.
And I think we'll go from there. Zeev, do you want to go ahead? We're running out of time.
Yeah, we are. So I think you've done an excellent review of the topic, and everybody is going to get your the slides that you have had as well as the presentation, so they can review it. We are now going to move to the Q&A session. And before we do that, just a couple, actually just 2 comments about your presentation, Andrew. I just want us to all be careful from some of the drugs that you have mentioned that would not be proven yet. So all kind of oils, and I'm not sure there is a lot of data yet to support that. I'm also going to say that as far as the liposomal bupivacaine, one of the biggest challenges of people who test that the drug is that they don't realize that really what you look at is the differences in day 3, 4, and 5, and not in the first 2 days, because the first 2 days there shouldn't really be any difference between them, because it's a question of the half-life. So I'm just going to refer your audience to go to the literature to really understand the benefits, for example, of that drug. Now, with that in mind, I have my first question to you guys, and if we can keep the answers relatively short, that would be great. The first question is really about how does your facility provides surgery in your ASC right now, this second, with COVID-19? Are you testing every patient? If the patient is positive, what do you do with that patient? Are you testing your staff? If the staff is positive, what do you do with that patient? Can you start, Randy? Do you want to answer first? And I know you have a huge organization, so just try and answer.
It's a big organization. I'll tell you, we spent a lot of time at the very beginning of the pandemic putting together a very science-based algorithm for all people who enter the hospital, whether it's a staff member or a patient. That algorithm is the floor, not the ceiling. And in many of our markets, either because of surgeon preference or candidly what our competition is doing, we may accelerate that and actually test more often than what a scientific algorithm may recommend.
Excellent. Brandon?
We are testing every patient, and we're following CDC and all the guidelines that are coming out. We've tweaked policies probably 48 times, I think, since the beginning. We're staying current. We're sending out the most up-to-date data possible with the most up-to-date policies, with recommendations based on guidelines. And for our staff, we're doing that same thing. We're making them stay away and quarantine for 14 days. Again, it's a big organization, and we've really tried to come through with providing the most up-to-date data and the most up-to-date policies to protect both the staff and the patients.
Great. I just want to remind you that the CDC came up yesterday with a revision in the guidelines, and now you need only 7 to 10 days in isolation. So just remember to tweak that. Andrew, anything in your practice, what do you do?
Really no different than my colleagues. Every patient is tested. Every patient is asked to quarantine from the time of test, and we ask them to quarantine postoperatively as well for a minimum of 2 weeks. Although, again, I worry that some of these patients, they're still in a very inflammatory stage. So I worry that if they go out too long and do two things too quickly, they're at risk. So in our booklet, we actually ask patients to try to quarantine for 4 weeks. I'm not certain, I don't have a way to measure that, but I do think it probably makes sense.
Okay, so next question, again, quick round. Brandon, especially, we talked a lot about the various elements that it takes to do surgery in an ASC settings. I did not hear anything about instruments. Maybe I wasn't listening well, but is there a special sense of instruments that are needed in ASC? Is there one manufacturer that does more than others? What's going on there?
We really stick with surgeons' preference. We're not here to tell surgeons what Legos to play with, if you will. They can choose their own that they have the best outcomes with, and they can control their OR times the best with. I think if you try to make somebody use something they're not used to playing with, your outcomes are going to suffer from that, and your OR times are going to be extended. The main thing with vendors, Dr. Kain, is getting them to get these instruments into the ASC 48 hours before, because like I said, a lot of these SPD departments are maxed, and if the vendors are coming in and dropping trays off in 24 hours, what that directly means is your SPD department in the ASC is getting out at midnight because they're trying to get these trays run and all the BIs and indicators, making sure everything's correct. They're working evening and night shift.
So do you think that there is a direction there for one-time use of instruments?
It's getting there, or you're hiring a second shift.
Okay, Randy. Any thoughts about this?
No, I mean, listen, I think, all the things that Brandon said are spot on. I mean, and to your point around single-use instruments, I do think that, COVID has accelerated not just the hospitals, but the vendors to think how can they create systems for workflow that are far more efficient. And I do think that there will be innovative solutions around instrumentation that we have not seen that are going to be accelerated because of the environment that we're currently in.
Andrew?
So I can tell you that pre-COVID, I didn't really have a lot of interest in single-use instruments. And we now use only single-use instruments for the knees, and we are getting there for the hips. The knees, we only open the size we need for the tibia, the size we need for the femur. It limits how much stuff is opening. My staff at first wasn't, no one was real keen on changing from the convention. Everybody likes doing what they're used to. But now my techs all love the disposable, and it's very cost effective for us. And it's, it's CO2 neutral. So I think overall carbon neutral and cost effective, techs like it, I'm happy with it. And it does help with the turnover. Makes a big difference for what Brandon's talking about.
Yeah, Brandon, I was a bit surprised when you talk about not affecting the surgeon's selection. That sounds like an ideal world, but don't you try and somehow control the implant costs, or it's not really your role?
What we found is that when patients transition from the hospital to the ASC and we pull instrument counts from instrument trays at the hospital, those total joint trays contain instruments that 12, 15 different surgeons used. So if you truly pull out the instrumentation that the specific surgeon that's going to perform the total joint in the ASC setting, in some cases you're cutting that instrument count down by 2/3.
Interesting. Okay. Andrew, I was happy to see that you mentioned nutrition, because that's a topic that's not typically talked about yet in orthopedics. So I'm going to actually ask Andrew, or Brandon rather, do you guys pay any attention to nutrition yet as an operator of 220 facilities?
Our focus in the ASC setting is providing that food for the 23-hour stay and making sure that it is addressed in the boot camp book, like Dr. Wickline referred to. Other than that, I think it's our job to make sure that the patient's read it and is being accountable for the data that's presented, and that we can provide them food for overnight stay. We lean on the surgeons really to go in depth in that topic if they wish to do so.
Yeah, so I will just inject a touch of my opinion. I think at the end of the day, it would be great to standardize procedures. And nutrition has a huge role that we just are starting to understand. And it goes beyond just providing the food. It really goes making sure that the patient is ready on multiple levels. And so, for example, albumin is nice, but there are other measures to do it as well. And I see Randy nodding. I'm sure that they're thinking about this topic already. It's kind of a huge topic. I'm going to maybe time for one or two more questions. So I'm going to talk about bundle payments just for 1 second. Does that, how common do you see it in your practice right now? And do you think this will change? This is a loaded question. Let's assume that the administration will change. Let's just make an assumption. Do you think that will change with a change in Washington? Who wants to take it first?
I'm happy to jump in, Zeev. Now, I think that the idea that we need to think beyond the acute episode and think about it as an actual episode of care that begins before the patient enters the hospital and ends after they leave at some point in time is an absolute necessity. And I think that the government and CMS kind of started us down that road. I think a lot of the large payers are trying to work within that space. Interestingly, the administration of it is more challenging than you might logically think it is. So I believe that there are going to be some innovative solutions that bundle payment is a loaded term because it means different things to different people. I think the fact that we're going to be responsible for an episode of care, and by we, I mean physicians, hospitals, anesthesia, I think an aggregate of humans need to be responsible for an episode of care. And through that aggregate of humans being financially, fiscally, and clinically aligned, we're going to be able to move the needle on improving care for patients. And it's going to be aligned with what the payers want as well.
Yeah. Brandon?
Yes, sir. We lean heavily on our managed care team at Surgical Care Affiliates to work with these bundled payments and these contracts. But I think more importantly, what we do from the clinical side is we really try to encourage centers to apply for, through their accrediting bodies, for centers of excellence, and that increases their reimbursement. So the Joint Commission and AAAHC have a process that ASCs can go through to be declared centers of excellence to increase their reimbursements.
Excellent. And Andrew, I noticed you talked about bundle payment, and you talked about how much you were able to make and so on. It's a very touchy topic. Some of the top organizations in the country are now almost buying out of their arrangements because of it, although there is a new BPCI coming out for 2021. Can you elaborate a little bit about that?
Well, I think the reality is that many people have not had success in, CJR or BPCIA because you're taking an average, there's no real incentive, I think, for surgeons to, if you're in a large group, you've got some high performers and you've got some low performers, and then you end up with this average. And I really think that's why Rothman's numbers, they were hard to, when they published or presented last year, they were hard pressed to beat their number, because they've got all these different people, and it just turns out that it's a B+ grade or a B grade. Let's face it, there are A surgeons and there are C surgeons, and I think we need to identify. Surgeons need their own report card, and so I think that's why these programs are failing. There's no real clear report card. It's hard for me to assess, am I doing better than the guy down the street? Because there is no national report card showing me these numbers. Because if there was, if he's doing better than me, I want to go visit him. I want the same for my patients. And so I think that's the real answer, and why these programs don't really work that well, is that it's hard to identify who are really the top players. And if you're in a large group, all your numbers get muddled into an average.
Yeah, I think that's all great points. I think, Andrew, we just have to remember that there are more players than the surgeons at the end of the day, and the success of a program many times is determined by the other players and by the infrastructure that is in place. And so I believe that there is a tremendous amount of benefit, just like Randy said, to these programs. It's just tinkering enough to understand how they're doing. I mean, with a GDP that is almost 20% of our GDP going to healthcare, it just doesn't make sense always. So I do think that it's time for innovative programs. And so, for example, we talked about vendors and instruments. I know that some vendors, such as Medacta, are doing these programs in which they partner with the surgeons and with facilities and actually work on it together. Okay, we are right on time. So any departing words for any one of you guys? Anything that you want to, last message to give? Nothing. Okay. Anyway, it's a pleasure to be here. You're a wonderful group, and I think people have really benefited from your expertise, and they can take what you said and tomorrow morning implement it all. So thank you so much. Thank you again for Medacta for sponsoring it, and everybody have a wonderful and safe day. Bye-bye.
Thank you.
Bye-bye.
Thank you, Zeev.
Thanks.